Lung ultrasound technique is all about reflections. If we can break down how we optimize a reflection, we can make lung ultrasound easy. So in the next few minutes, I'm going to give you some tips and tricks which will help clarify this abstract art. In this session, we will define different structured lung examinations, hone in on how different probe motions affect the image on your screen, and specifically turn our probe motions into a set of 3 moves: slide it, rock it, fan it. And by the end of this, you're going to know all the major sonographic structures you're looking at and leverage these to troubleshoot your image. First things first, let's just make sure you set yourself up for success. Power on your machine and start your encounter. Enter the patient information so you can be sure to save your images. When you're scanning the lungs, you can really use any probe. The key here is that it depends on what structure you're most interested in. If you're evaluating for pleural pathology, like pneumothorax, or evaluating subpleural consolidations, then the linear probe is going to be your probe because of its improved resolution. If you're interested in the lung ultrasound pattern, like A lines or B lines, then the curvilinear phased array probe is going to be your choice. I just want to contrast the differences of what we see when we're using these different probes. When we use a linear, you're going to see that we have much better resolution of the structures in the near field. You can clearly see the muscle tissue and the skin and soft tissue, where when we use the phased array or a probe with a lower frequency, we lose that resolution. But what we lose in resolution, we gain in penetration. So if you note, the depth on this image is going to be all the way down to 10 centimeters as compared to 4 centimeters in the linear probe. Next, let's choose our preset. Many machines have a lung preset. This preset will be optimized to evaluate the lungs. However, if you do not have this preset, you can choose abdomen. Images collected in the abdominal preset can further be improved by turning off post-processing functions such as multi-beam technology and tissue harmonic imaging. Okay, let's turn to how we structure our examination. The way we structure our clinical examination depends on the clinical question we have. Currently, the POCUS community advocates that the standard protocol evaluates 4 different zones bilaterally. These can be seen here. One way to think about this is that the examination should evaluate the upper lobes and lower lobes of the lung, and on the right side, the right middle lobe. So if I'm doing a volume examination, I will typically complete the 8 total anterolateral zone protocol. However, if I'm searching for pneumonia, I'm much more likely to evaluate the posterior zones and add the 2 posterior zones pictured here to optimize my sensitivity of the exam. If you're completing an examination like the cardiovascular limited ultrasound or CLU exam, this just involves evaluating zone 1 and zone 4. There's not one right exam. A lot of this just depends on your clinical question. And so I think the easiest way to determine what should I be looking at is to ask, what is my clinical question? What am I looking for? And how do I best do an evaluation that satisfies the questions I've generated? Before we move on to the technique, I want to take a step back and review anatomy as it relates to our sonographic image. Anatomy and its spatial relationships provide the underlying foundation to get an optimized image. To start, as we move from the chest wall into the thoracic cavity, we're going to encounter skin, soft tissue, chest wall musculature, and ribs. Locating the ribs can help you identify the pleural line, as the pleural line should lie deep to the ribs. Let's rotate the anatomy to match what we should see on our ultrasound and locate the structures we just talked about. Moving from the top of the screen to the far field, we see the epidermis and soft tissue, our relatively hypoechoic chest wall musculature, and our ribs with the hyperechoic cortex with associated shadow. The hyperechoic line just below the ribs is our visceral parietal pleural interface, or pleural line. Let's re-emphasize the point here that when we're obtaining a lung ultrasound image, our goal is to match the curvature of the lungs, or to reconceptualize it as getting in front of the mirror. So how do we actually do this? I like to break it down into 3 simple steps: slide it, rock it, fan it. So let's look at the anatomy to understand why we're using these moves. As we slide the probe head to foot, we center the pleural line on the screen. When we rock the probe, you're aiming to match the head to foot curvature of the lung. So at the apex of the lungs in the anterior chest, you will note that the beam is somewhat aimed towards the patient's feet. Pay attention here. See, as you rock the pleural line, rock the probe, the pleural line flattens as the field of view swings from left to right across the screen. Finally, fan the beam to match the lateral slope of the lung. In the thoracic cavity, the lungs curve. You're aiming to match this curvature, this slope. In the anterior chest, this involves fanning the beam medially. As you fan the beam, your eyes should be focusing on the underlying pattern to determine when the image is best optimized. When the pleural line is centered and flat, and you can clearly see A lines on a normal patient, you are directly in front of the mirror, and you have optimized your image. Again, let's focus in on this as we complete the entire anterolateral examination. Slide to center the pleural line, rock to lay the pleural line perfectly flat, fan the beam to match the curvature of the lung. As you move laterally, your beam should be fanned more medially. Again, it is key here to make a mental representation of the lungs in the thoracic cavity to help you optimize your image. Now, as we move from zone 3 and move to zone 3 in the axilla, note how your beam is actually somewhat oriented to the patient's contralateral hip. And if we think about this and how the lung curves down toward the feet at this location in the thoracic cavity, this makes sense how our probe should be oriented. Watch how the probe moves here. Sometimes a slight rotation of the probe to fit within the wind of the ribs can be helpful as well. Got it? To wrap this up, the major things here is to conceptualize your spatial anatomy, then slide to center the pleural line, rock to lay the pleural line flat, and fan to match the lateral curvature of the lungs. Slide it, rock it, fan it. Okay, what about effusions? I like to change my precept to abdomen before I start to look for effusions. It'll make it much easier to pick up fluid as you're looking into the thoracic cavity. I also want to re-emphasize that conceptualizing the anatomy and then pointing your beam at the specific structures is really key. Don't look at the screen first. Point your beam at the spine, visualize your beam bouncing off it, and once you've done this, then take off your blindfold and look at the screen, and then correct from there. When we're actually doing this, I start with my probe at the posterior axillary line in the coronal plane. Getting your knuckles into the bed, especially on the left side, is going to be important here, and this will help you ensure that you're going to be evaluating the dependent space. The thoracic cavity usually divides into the abdominal cavity at a line that extends laterally from the xiphoid process. Perhaps even an easier way to visualize this is to plant your probe right at the lowest aspect of where a bra strap would be. Okay, now let's look at the anatomy in the sonographic image. You can see on the anatomical representation that your beam is passing through the liver here as it travels towards the spine. Anatomical landmarks are going to be really helpful here. So if you see your aorta or your IVC, you know your beam is anterior to the spine. On the left, if you see stomach medial to the spleen, you are also too far anterior, and that is a really common mistake. If you see kidney, you know your beam is traveling in the retroperitoneal space, and you're going to be relatively close to having a good image. The abdominal cavity should take up at least half of the sonographic image if you're doing this right. When you look at the sonographic image, you can see the liver here with lung tissue on the left side of the screen. As the beam travels to the far field, spine should appear as a lumpy, bumpy, hyperechoic line. Look for the aorta and the IVC as the beam fans through. Remember, the IVC goes through the liver. Additionally, it can be helpful to correlate the vessel location to the spine. Finally, a slight rotation to fit within the ribs can be helpful to optimize your window here. Try locating all these different structures at bedside and correlate the different probe motions to what happens on the ultrasound image. Now let's look at a real sonographic image. The image on the left shows an optimized image with the spine in the far field. The image on the right shows an image that the beam travels anterior to the spine. Try to find the aorta and the IVC as the beam fans through. All right, let's take this home. Let's review our key takeaway points. Number one, Clinical questions determines the structure of your lung exam, but the standard exam involves 4 anterolateral zones per hemithorax. Number 2, we saw that how different promotions affects our sonographic image. Number 3, we developed a framework to get an optimized image. Slide it to center the pleural line, rock it to lay the pleural line flat, fan it to match the lateral curvature of the lungs. Slide it, rock it, fan it. And finally, remember your anatomy and try to conceptualize anatomy before you look at the sonographic image. This can really simplify your ability to get an image.
Remembering these key tricks can help you own the lung exam and make you feel confident next time you evaluate your patient.